Hi everyone. I'm not sure how these things get started. I'm fairly new to this. I'm Ray Berry. Can everyone? I'm assuming everyone can hear me. Um, yeah. So I'm the palliative care from palliative care, and also the medical director of our new hospice in Scarborough, based at Yi Hong Center. Um, we'll get started. I'm just going to share my screen. Um, assume everyone can see my screen now. Any troubles, please let me know. So today I'm going to talk about something that I think is really, really important. A lot of things in palliative care, we start early on in palliative care. We do a lot of goals of care early on and ongoing following people with symptoms through their course of illness. But all of this can go wrong if you don't do this well at the last hours of life. This is the day that really is remembered the most by the family, and it's so essential to control symptoms at this time. Um, uh, if the family feels symptoms are not managed well during this last day, there's really long-lasting distress. This distress is shared by the care team. I've had a couple of times when things have not gone as well, uh, real agitation or poorly controlled symptoms. Um, the care team stays distressed for a long time. The family remembers it really for years. So this is so vital. So it's why I want to focus on that today, because there's a few little points with appropriate care and attention to some of the symptoms. It can really be a comfortable and actually even rewarding experience. Um, just to review, this is obviously view when is this getting to be the last hours? Most people are unresponsive, and it's not uh, really most times people just become unresponsive and kind of fall asleep, and it's really not a big deal. But it's this. I'm going to focus on the ones where symptoms intervene and cause a lot of distress. So the things you're looking for, I think probably most people would know this. You start seeing the mottling in the skin, the coolness in the extremities, especially the hands and the feet. You'll touch them; they'll be bluish and cold. Um, People obviously have an inability to swallow, decreased urine input output. Um, the change in breathing pattern. There's a lot of different end of life breathing patterns, but quite often the most one you'll see is just real periods of apnea. It seems like people have stopped, and this causes a bit of distress. I'm going to talk about breathing in a few minutes. Um, Increased restlessness often happens, so I'm going to give you some tips on how to handle that. You'll see their eyes change. They get sunken, they get glassy, they don't focus. Along with the mottled skin, cyanosis, gray pallor. You'll see that color. Once you've seen it, you start recognizing it, that grayish, kind of almost yellowish pallor. And a buildup of respiratory secretions, which I'm also going to cover a little bit of an approach to that. Um, this is as a start, and this is something you anticipate before the last hours of life if you do this right. So obviously at the end of life, and it causes a lot of anxiety for the families. They're no longer eating and drinking, and I think most of us know that eating and drinking at this point doesn't change anything. But families don't understand that. They're saying they will absolutely associate the lack of eating and drinking with the fact that they're now going to die because they're not eating and drinking. It's of course the other way around. They're dying, so they can't eat and drink. So I anticipate this with if you're following somebody and you know they're going to be in this, it's really good to address this so that when it comes up, they're aware that they're not going to eat and drink. So I anticipate the family's going to be concerned. And I explained there's going to be a time when the body can't process food and fluids. Though no matter what we do, it won't make a difference. So that when it gets to that point, the anxiety is not there. They're kind of come to you and say, yeah, we're at that point that you talked about, so that they're not pushing for food and fluids. But food and eating have very strong emotional and cultural connections to people. Uh, the fact that they're not even feeding their family member feels really wrong to them. It feels like they're not providing care, especially at this stage. So you really have to make them understand. And I'll even go into a little bit of very basic physiology and explain that, at this point, the body can't use any food or fluids, that we give them and they just sit there because the body's not working anymore. And we know this a lot. There's a lot of cachexia going on even before this, where the body's not using this. The body's metabolism starts breaking down in all chronic illnesses. So I really explained that, if we give this, it will just sit there and make them feel worse. And we know that, and I can even say, if we give water or fluids of some sort, saline, or it increases edema and congestion. I don't know if you can think of any time when you would give fluids at the last day of life. I'm going to give you one little tip that I do sometimes give a very small amount of subcutaneous fluids. And this is the ones where you've gone through all of that discussion. You've talked about it. You've really explained why it's not. And sometimes one family member just cannot handle the fact that they're not getting something. They're so distressed. I think it's totally okay in those cases to give a little bit. I give sub-Q fluids at a very low rate. People don't honestly care how much you're giving at that point. And you've got to give a very low rate because you do know you're going to increase the chest congestion and edema. So I have in those cases given, 20, 30 mils an hour of that. It's totally fine. I had one last year where the whole family agreed and understood, but the patient's husband just couldn't take that his wife was not having any fluids. I gave it. The family was really happy with it because they understood, but it made their dad happy. At the end of the day, it did make that last day go better. So although most of the time we really avoid it, there is a time when, you're treating the whole patient, the whole family. It's not, from a medical point of view, we know it's not helpful and can potentially harmful. I always tell people that if I do this, I'm going to be watching very closely and listening to their lungs really carefully. And that when I go back later and say, hey, there's a little bit more congestion in their lungs, then they're really willing to stop it at that point. So just as a little tip is when we do, because sometimes I do all these talks and I talk to people about why we don't give fluid and food at this point. And then somebody might come in and see me giving it. I'm treating the whole family. I'm treating all of their anxieties. So I'm not going to focus on all the symptoms, but I'm going to focus on ones that come up really at the end of life. And I'm going to talk about dyspnea, shortness of breath. A large number of patients experience it at this end of life, and it's probably the most feared symptom I would find. People are afraid of pain and nausea to some degree, but people are really afraid. What if I can't breathe at the end of my life? And families are really worried. Will they be unable to breathe? Will they feel like they're choking? Will they feel like they're being suffocated? And so people are very afraid of this, and it's really good to reassure them that we can treat this. Well, there's lots of reasons. Say 60 to 75% of patients experience this at the end of their life. There's lots of mechanisms for this, of course, apart from those with clear underlying lung disease. People aspirate, people get pneumonias. There's often effusions and just the generalized weakness of the lung muscles. So people are not breathing well at the end of their life. Now, one thing to reassure people is that the change of breathing patterns that you're going to say are not the same as shortness of breath. People will say, oh, they're having big breaks in their breathing. They didn't breathe for 15 seconds or 20 seconds. Reassure them that that's normal. That's not the same as shortness of breath. You'll see these patterns. The agonal pattern, I'm going to just mention, the agonal, it comes with big gasping breaths at the end, and people really feel that any sort of gasping is discomfort. It's not. You explained that sometimes people they're just taking that big deep breath. They're not regulating their oxygen and carbon dioxide the same way, so they need a big deep breath, and it seems like a big gasp. But you want to reassure people that that's not shortness of breath. So how do we treat it? I won't go into how we tell shortness of breath, but just when someone seems totally distressed, start with non-pharmacologic methods. And I'm just going to mention fans. Fans are always sometimes a little more problematic in hospitals these days. Maybe, but They do work. And you know, everyone knows they work. Even apart from medical, well, actually, apart from medical, people know they work because what do you do when you're short of breath, right? Get them some air, blow some air on them, open a window. Everyone knows this intuitively, but we don't use it a lot. And there is some physiologic mechanisms for it. It does seem to stimulate the trigeminal nerve when air is blowing on the face, makes things feel a little easier to breathe. So I love fans with this and just the cooling effect of it. Um, a lot of people get oxygen put on. I find even on my when I'm doing palliative care units or uh, hospice, you know, often people put oxygen on. It's not really shown to be of benefit if they're not hypoxic, you know, like if an O2 sat less than 88, really doesn't help, but it probably helps just by the way, as I mentioned, the blowing air. Just air movement makes people feel better. So uh, I try to avoid it unless they're really hypoxic. It just it's a little more looks a little more interventional. Uh, Having oxygen on people's faces, it's a bit of a barrier to the family. So uh, I try not to put it on unless I need to, unless I really think there's going to be benefit. So yeah, measure it. That's one where you'd measure the oxygen levels, and if not, you try not to put that on. Repositioning. That's sometimes it's just a matter of where the fluid is in the lungs, or just finding. And there's no right position. There's no you know. And sometimes people will ask, "What's the right position if someone's short of breath?" There isn't one, really. You know, there's some classic ones with when people are earlier in their stages. You know, they tripod or sit up. Um, or just propping themselves up, but there's no absolute right way. Find the one that seems to alleviate their distress, and just sometimes just repositioning, changing position helps. Um, so actual medical treatment, and if you take anything away from this uh, talk today, take this away. Opioids should be used to treat dyspnea and end of life care. There's incredibly great evidence for this, and it's really underutilized. Uh, Even amongst a lot of medical treatment people, they think, you know, opioids are for pain. They're not in pain. And they really do treat dyspnea extremely well. And all forms of dyspnea, you know, cancer dyspnea, CHF, COPD. Um, just going to point to a trial a few years ago in JAMA, morphine for the treatment of dyspnea in patients with end of life COPD. Really excellent trial just to show that this really works, because I do find, especially in COPD, for instance, end of life, I don't see opioids being used until it's really extreme, and they should be used earlier. Uh, they took 124 patients with severe breathlessness and showed clinically significant improvements with morphine. And the big thing that worries people, hypercapnia is not a problem. It doesn't slow the respirations and cause CO2 buildup. I mean, you got to go carefully. You got to uh, titrate it really carefully, but it really does help. So uh, if you take anything, and when you see this dyspnea at end of life, make sure they're on opioids. The mechanism of it is probably a central perception of it. You know, dyspnea is not really doesn't go along any different pathways than pain pathways. The body perceives it as discomfort and pain. So you can block that. You're not blocking what's going on in the lungs or uh, any of the actual breathing. It's just that the person's not aware of it. So uh, at this stage, that's totally good enough. The fact that they're not aware they're short of breath is all you're after. So uh, there are probably some peripheral opioid receptors in the lungs that are also affected. There was at one point, because of this, a lot of push in palliative care to give nebulized opioids, but it's found that it doesn't work as well, and you don't get the same effect on the central perception of pain. So you give them systemically. And this is a big point. There's no hastening of death or increased respiratory depression if you take this carefully. I see all the time a real fear of this, because at the end of life, people's respiratory rate is low no matter what. And so don't, at this stage, don't hold it if the respiratory rate is low. You know, I'll see orders sometimes where people say, hold hydromorphone if respiratory rate less than 8 per minute. And of course, the person's respiratory rate is 8 per minute because they're dying, not because of the opioids. So if you hold it at that stage, it means someone's not going to have the relief that they need. So you can tell people, if you really go very carefully, there is no hastening of death with this. It's been well established. Um, I guess I should point out there is the occasional thought that, and I say if it's titrated carefully, there's no risk of respiratory depression. Occasionally, and this is just a very rare thing, just so you have it in your mind. Occasionally, you have to titrate up actually more rapidly in this last stage. Sometimes respiratory distress really escalates at the end of life, and you've got to control that. So you do increase the dose faster than you hope to. It is possible that could slightly shorten life at that stage. Just to be honest about that, it's the ethical principle of that. It's called double effect. You're not giving it, and you're not giving it with the intention of shortening their life. You're giving it fully with the intention of alleviating their symptoms. So from an ethical point of view, it's thought to be extremely clear. You're never giving opioids at this stage to shorten life. If it does happen, it would be shortened by minutes, and you've achieved your main goal of keeping them comfortable. So intention is the key with this. And I said that's an extremely rare outcome of giving opioids at this stage. It really doesn't hasten death. If anything, I find it allows people to live a bit longer because they're breathing more comfortably, and they tend not to die quite as quickly when they're comfortable. So if you're giving opioids, I'll just give you a little quick points. I mean, you start really low if they haven't been on them before. Hydromorphone is pretty much the way to start with most people. It's generally safer. A lot of our patients are elderly. There's a lot of decreased metabolites compared to other opioids. So it's a little cleaner if you've got some decreased renal function. So start really low. You're giving the sub-Q, and that's the route. So, and I'm not IV. It works really, really well just putting a little butterfly or a little sub-Q port if you need to, or just inject it, just sub-Q. So 0.25 milligrams is a good starting dose. You can go up higher, you can go to 0.5. Consider giving it as a standing dose. You don't have to wait for them to get really short of breath. You can give it every 4 hours, and then top it up with every hour doses. I mentioned opioids not as effective for this, really totally out of favor. So if you come across that, I said it was really in favor several years ago, I guess now, because it's thought that it would have a direct effect on the lungs, but now you give it sub-Q in this state. Morphine's an acceptable alternative. Morphine's less potent, so about 2.5 milligrams sub-Q every 1 hour PRN. And if morphine or hydromorphone allergies or severe renal failure, there's other options such as fentanyl. Obviously, I'd really encourage you to get back up in that from palliative care. And in any case, all of these are great to have backup from palliative care, but I'm just going to try and give you some points to do when you're managing it yourself. But if there was severe allergies or you needed to go past the basic opioids, then definitely get a consult. There are other adjuvant treatments. I said I want to really focus on making sure opioids are part of the treatment. I often find that people use these adjuvants first and then add opioids. Really no benefit to that, especially at end of life. Bronchodilators, I find a lot of people put on puffers and try to give these. Really, they're only useful, especially bronchodilators, if there's reversible airway disease, and that's not usually the underlying issue at this point. If there's other things like CHF, you can continue diuretics, of course, diurese them, keep the pulmonary edema down. Corticosteroids, they're helpful for so many things. And sometimes with some of the really underlying mechanisms of end-of-life shortness of breath, lymphangitic carcinomatosis, COPD, swelling around the superior vena cava. Obviously, in this cases, corticosteroids are absolutely primary. Not bad to add them in other cases, but I find they're not usually useful adding them right at the end of life. Benzodiazepines are an interesting addition. People do feel anxious with shortness of breath. Now, if it's really truly this talking about this end of life, last day, they're usually not that aware. They're usually just distressed, but not fully conscious. But if they are, the shortness of breath will make them extremely anxious, and it's a cycle, right? So you get anxious, you get more shortness of breath, you get more short of breath, you get more anxious, and you got to break that cycle. So sometimes I'll use benzodiazepines to break that anxiety, shortness of breath cycle. So a low dose of lorazepam can be quite helpful for this. If you do all of this and the person's still gasping for breath or really, really clearly distressed, you may need to sedate. This is a really severe, troublesome symptom, and you may need to do sedation and actual palliative sedation. And I'm going to get back to that towards the end of the talk, just to give you an idea of what you can do if you really, really can't control the symptom. Related to dyspnea is airway secretions. So at the end of life, cough and swallowing reflex is impaired. So all the saliva and respiratory secretions they collect, and they collect down in the upper airways. And you hear this. So it was always called, and families will be aware of this term, the death rattle. Don't use that term. It's a little scary. I move people away from that. Sometimes families say, "Is that a death rattle? What's going on with this?" And I say, "Well," and you explain what's really going on. They're just not swallowing their secretions, so they're just sitting there. I explain it like, water in a hose. The air is moving over it. You hear it rattling. It's not causing any distress. We're pretty sure, almost all of this. It's just part of the dying process. Doesn't cause any discomfort, but the families feel distressed by it. They hear it. They hear this loud, sometimes very loud rattling, crackling noise of their breathing, and it does make them upset. So you sometimes do want to treat it. My first step is to tell people that it's really not uncomfortable, that don't worry about it. But for those who find it really distressing, anticholinergic meds are the treatment. So they just dry up. None of them are specific to respiratory secretions, unfortunately. So they do dry up everything. Your eyes get dry, and just the mouth gets drier. So you really want to use it only when people really are less aware. A few different choices. They're all same anticholinergics. Glycopyrrolate and scopolamine can be given by injection. I usually inject them. Scopolamine can come in other forms, which I'll touch on in a second. Differences between them. Glycopyrrolates does not cross the blood-brain barrier, so it doesn't cause sedation the way most anticholinergics do. Most of them cause pretty extreme sedation. So scopolamine does. Makes people very sedated. So I just kind of choose between those based on what I want. If I think someone's a little more aware and doesn't want to be sedated, I'll use glycopyrrolate. Often sedation's a benefit at this stage. So I don't, if they're really unresponsive and gurgly and you want to give something, scopolamine's fantastic. They just, you use the sedation as an extra benefit. They're calmer, and the respiratory secretions are dried up more. Comes another, if you can't have subcutaneous access for some reason, sometimes in the home, this can be an issue. You can put a patch on. Of course, everyone's pretty much aware of scopolamine patches, used often for motion sickness. People use them for traveling, but can be used at this stage for drying up respiratory secretions. Atropine's very, very available. Put a couple of drops under the tongue. Of course, very, very broad anticholinergic effects, but absorbs very easily under the tongue. Well, sometimes people ask about suctioning. You can suction the mouth, but you can't really get to where this stuff is. It's a little bit lower down, and you really want to avoid deep suctioning. It's causes a lot more distress than it's worth, and you don't really get into the airways where the secretions are. This is just an article that I came across a little while ago. It potentially would change my practice, although it hasn't. I'm talking about treating this respiratory secretions when you see them. there was an article, it was done in the Netherlands, about prophylactically giving this. And they actually did use the term death rattle in their article. I'm not quite sure why, but they did, maybe to let people know exactly what it was they were talking about. And they gave it prophylactically. They saw people with all these end of life symptoms or all the end of life signs and thought, should we give this prophylactically? Would it make people feel better? And so they gave it, and they found there was a significant decrease in respiratory secretions. So 13% of people got them versus 27%. And that's about right. I think 27% is about the rate that normally get it. So they cut it in half. Just something to think about. They thought that there also conclusions were that people felt a lot better about it, that not hearing those respiratory secretions was useful. Has not changed my practice to give it prophylactically at this point. But if you think it might be beneficial and you think a family would be really distressed, you could give this prophylactically. So it's an interesting potential change in practice that I haven't seen taken up yet, but something to consider. Terminal delirium is another symptom I want to get into. So this is really, really distressing. It present as confusion, restlessness, agitation. They're moaning, they're grimacing. It looks a little like pain, and sometimes I think maybe it can be pain, so I'll treat as though it is. If that doesn't work, then people are just delirious. I think you'd probably know delirium at earlier stages. The approach is to find the underlying cause if you can and treat the underlying cause. So, and there's lots of causes of delirium in palliative care patients. At the end of life, you're not likely to find a reversible, easily identified cause. We're not going to do blood work. We're not going to be looking for urinary tract infections and even things like constipation that we really want to treat. At this stage, if they're really in the end of life, it's really hard to find what the underlying cause of this agitation is. People do get a terminal delirium, probably multifactorial. And the key is just to calm them down. So again, start with non-pharmacologic interventions, quiet lighting, quiet environment. Just the lighting's not bright. When I say quiet, not bright or dark, just a little bit of light, calm reassurance, speaking calmly, quietly. Really avoid physical restraints. It's a terrible thing to put people in restraints a day or so before they die. We really, really don't want to do that. And it actually often increases agitation. So medications, as you might expect, the mainstay is antipsychotics at this stage. It's controversial how much antipsychotics work in delirium, but they do calm people down at end of life. Standard ones to give, and obviously you're not giving these orally at this stage. You've got to give them by injection. Haldol's still a great medication. It's been around for so long. You can dose that. It works really well sub-Q. Again, a lot of people will give it IM. You don't need to. More painful. Just give it under the skin. You can start at 0.5 milligram, go up to 2 milligrams. You can inject it. It's got a pretty wide dose range. You can get up to 5 milligrams, and if you need to, and repeat it as needed. You don't have if you don't have sub-Q access, olanzapine does have a disintegrating oral tablet that you can put in the mouth. Zyprexa, that will work quite well too. I'll give you a drug that we use a lot in palliative care. You may not even be that familiar with it. It's an old antipsychotic. So this is methotrimeprazine, Nozanan. And we use it because it fell out of favor for the reason that it really causes extreme sedation. So as an antipsychotic, people felt way too sedated, and it blocks so many receptors, adrenergic, dopamine, as dopamine as all the antipsychotics do. Histamine, cholinergic, serotonergic, probably causes some pain relief. So we use it because it's very sedating at this point, and also does these other blocks these receptors that are actually pretty beneficial at the end of life. It's so old that they took it off the market a couple of years ago, and basically the palliative care community really rallied to get it back. It's so helpful. So I start still with some of the other ones like Haldol, but I'll rapidly move to something like Nozanan, especially at end of life. You've got to get someone calm. It's very distressing for everybody if they're not. So you can dose that again, 6.25 up to 25. So, and again, if you needed that, that would be a really great time to get a palliative care consult. Other medications, benzodiazepines, possibly. They can worsen confusion. Sometimes people get more disoriented on those, but you can certainly add it in, lorazepam or midazolam. You need a really stronger, well, maybe not stronger, but gets in there fast to really calm somebody down quickly. And I put the doses up there. Midazolam, anywhere between 1 and 5 milligrams. Start low, obviously, because you don't want to overdo it. If you can't control all of these symptoms, palliative sedation is an option. So it's for severe refractory symptoms. You've tried all of this. The person is agitated. Their breathing doesn't settle. They seem to be in pain. They seem to be moaning. And you just need to get them calm. So we can actually sedate people then. And this is not, people sometimes say, well, if you put somebody in total sedation, is this a form of MAID? It's not. It's being given purely to get somebody comfortable. But it can cause a lot of concerns, even amongst the staff and the family. Like, how will they live if you're sedating them? And you really have to explain that, they are at the end of life at this point. You use this when life expectancy is already short. And multiple studies have actually measured the impact of sedating somebody at this stage. I gave an older study here from the journal Clinical Oncology that showed that survival was actually longer when you sedated somebody at this stage, because if they're at end of life and they're extremely delirious or shortness of breath, their life expectancy is already extremely short. You actually don't shorten it by actually putting them into a deeper sedation. Survival is the same or even better. So we're not hastening death by doing this. It's really is a last resort. Don't put somebody under sedation unless you really have tried everything else. But I like to put it out there to let people know, you know what, we'll do whatever it takes, right? If somebody needs something to be comfortable and at the end of it is just like make them sleep, then we can do that. And just so how do you do this? You keep somebody under constant medication, and this is absolutely you need a palliative care consult for this. Even if you're comfortable with it, I would really encourage you to do that. Get this done in, and ideally done on a palliative care unit where the nurses are very comfortable with it. So if somebody's at that stage, try to get them somewhere where they really have intensive palliative nursing and follow up. We use continuous infusions. If we're going to sedate somebody, you don't want them coming in and out. You measure this. I didn't get into the measurement of it. They're scales of sedation scales that you measure, and you try to keep somebody in the right, not over or under sedated, but definitely asleep. The first line I use is midazolam. Works really rapidly. You just infuse it steadily, subcutaneously, keep somebody in a really, we know it's good, right? We use it for all our procedures, and it just keeps somebody really unaware of what's happening. It doesn't always work with these patients. If you're healthy and getting a procedure, midazolam works really well. Some of our end-of-life patients with severe delirium, really, really restless. That's where I add some of the other medications I mentioned. Nozanan, in addition to midazolam. Sometimes phenobarb if I need to. It's an old medication, but it works. And then this would again be extreme and with specialist consult. If those aren't working, you get into almost the more anesthetic medications, almost like propofol, but we will use those, but that would be for absolutely extreme cases. But I like to put it out there because it emphasizes that, you know what, we always can find something. You know, we're not going to leave somebody if we've got to this point, say it's end stage dyspnea, and we've tried all the opioids and we've tried all the other medications, and now we've sedated. There's even other sedation we can try. So we never need to leave somebody in discomfort. Um, just finish up with a little bit of things of what to talk to be. You know, we've talked about all this, and the families watching you all this, and they just to let you know, they often need guidance. This is very simple stuff, but worth reviewing. Families will have a lot of questions, you know, and I'm talking about all these medications, and the person's unresponsive, and it's really good to give them a little bit of guidance on what to do at this stage. Doesn't have to be a lot. Families will ask questions like, "Can they still hear me?" Um, and I talk to people, how do you approach somebody at this point? I tell them, you know, their awareness might be greater than their ability to respond. They may not be able to respond to you, but they may hear you. Um, and so you speak as though they can hear, speak in a normal voice, and just give families ideas about how to talk, or just continue to talk to their family member. Um, you may need to go through a few little things. I'm just going to touch on this. This is almost a whole talk in itself, but families are often very conflicted at this stage, and they feel bad about it because they're kind of hoping that sometimes they'll even say, I hope they go, but they'll say, this is a terrible thing to say, but I hope they would go today. And give them permission. That's an okay thought, right? That's actually a caring thought. And it's okay to have that conflict of, you're hoping they don't go because you want them to stay, but you're hoping they go because you know it's been a suffering time. So give them permission, talk about that. Also give the family permission to leave the room. People feel bad. They feel they have to be there 24 hours a day, and they don't. It's okay to go. Sometimes, sometimes, sometimes people need to have that space. So it's okay to leave the room. I'll tell people all the time about people who really can't go until they have that space. So give them that. This is just a little point. Sometimes patients seem to hang on and hang on, and they're not going. You're not quite sure why. Patients sometimes might need permission to die. You can talk to families about that. Take that as it comes. Uh, you have to be careful whether you say this, but you can tell people that it's okay to talk to people and say, it's okay. You can go now. And so it's just things you can talk to the family about and help support them, because they just don't know what to do and what to say at this point. At the time of death, you don't know what you're going to see. Grief can be expressed in so many different ways. You may find that there's a lot of anger in the room. Don't in any way take that on yourself personally. They're angry, and they're rightfully angry sometimes. Not everybody, but you may run into it, and it's okay. You can acknowledge it and use that as a way to talk to them about their emotions. It might be sad. There may be a lot of physical symptoms. People pass out. People feel short of breath. I've had chest pain. I've had to send people to emerge. So be there with that. Sometimes people are very accepting. So if you're there at the time, just try to keep things calm. There's no rush to do anything. Let people know they can just take their time. Communicating with them, I just maybe some brief little tips, because sometimes even although family members don't know what to do, sometimes staff, or you don't know what to do in that situation. And there's no right answers to this. Just, I mean, it's even okay to not say anything and just be there with them. Simple things. You know, telling you you're sorry this happened. Sometimes people have said, "Oh, don't say you're sorry. It sounds like an apology." It's not. You're sorry for the situation. It's okay being there with them. Maybe talk about. I might just touch basically, and probably not too many people do this, but there's things not to say, I suppose. It's better to be silent than to say the wrong things. probably heard some of these things, some people, it's done with such good intention, when people say, oh, this is for the best, or don't worry, you'll heal, you'll get over it. These are not the times to say those things. People feel like they're offering help with that. Um, even some really things that come across actually very paternalistic, like, oh, she's okay now, she's happy now, uh, she's no longer in pain. Those I find not that helpful. Just be with them, tell them you're sorry, you're sorry this has happened. And I mean, it's okay to talk a little bit. I'll talk a little bit and reflect back if they're saying, well, we're happy she's no longer in pain. That's okay. But it's not really the thing to say. And certainly don't start saying things like, there's a reason this probably happened. You don't know these things. So avoid that. And I'll give you one little tip that I has found really helpful. So real practical assistance is there someone you'd like us to call? Can we help you with things? So people's minds are blank. So some very practical, like, help them guide what's the next steps. Like, let's just sit down and carefully do this. And one other thing that people don't think about, I found extremely helpful, and take this away as a real tip as well. And I'm not sure when you want to say this. It doesn't have to be said right at the time, but if you do get a chance to talk to the family, ask them if they have any other questions about the illness or treatment. There's been a couple of times when I found this to be the most useful thing I asked, because I find out sometimes they are absolutely going to carry away, oh, we're so sorry they got this morphine because it killed them. And it's, if I hadn't asked, do you have any other questions, I wouldn't have known that. I would have thought maybe things are fine. So gives you a chance. Closure is not quite the right word for it, but it does close up a little bit of your relationship with them. Say, hey, is there anything else you're thinking about? Or do you have any other questions about what happened? This might be a time, because can you imagine that they're carrying away this idea that, morphine killed their family member, and you didn't get to talk to them about it. So it's a really nice thing. Try to remember to wrap it up and ask a final thing when you get a chance. Sometimes at the time of death, that's not really the time to ask that. But if you feel it's a time, I'll often do a little with my patients. Most of the time I do call them afterwards and ask those things, and just to touch base to how they're doing. But try to add that into your list of things to talk about, and ask them if they have any other final questions. So yeah, just summary. Yeah, it really is a very, very important thing to do properly. As I said, there's long-lasting distress if it's not managed well. We can make a big difference with the careful attention to the common symptoms. So dyspnea, respiratory secretions, agitation, we can really make a big difference, and this can become a rewarding experience. And yes, and don't hesitate to involve us as palliative care. So thank you. Any questions? I'm happy to take any questions. I will somehow stop sharing my screen. Or any comments, anyone with experiences with this that they'd like to share? Okay. Maybe it was all very clear. Hopefully, I mean, you know what? There's never clarity with these, right? You're always going to run into a situation that you've never run into before. Even me, having done this many times. Uh, you know, just that last little point. I think, don't do any harm at the end. Make sure you don't you're trying to alleviate people's distress. Don't do things that are harmful. Uh, let the family know you're really there with their goals. Your goal is to make them comfortable. You're going to work with them together. They understand that you really won't go wrong. So yeah, thank you for attending. Any questions, of course, feel free to contact me or contact through the palliative care service. We're always willing to be involved. If if you're following somebody at any stage, we're definitely willing to jump in and manage them with you. Thank you.